So we're going to chat about urine drug tests. And Christina's right. We've done this talk many times. I will say that things have shifted, at least for me, with the experience that I've gained treating individuals during COVID. It's made me think about my approach a little bit. And of course, Christina did the land acknowledgement for where the BCCSU is. I actually work in Fraser Health. I live in Delta, and that is on the unceded, unsurrendered traditional and ancestral homelands of the Coast Salish and in Clapamix peoples. With regards to the Coast Salish communities in Fraser Health, we're really talking about the Katzie, Semiahmoo, Kwantlen, Coquitlam, and Tsawwassen nations. Some information about financial contributions. This program is supported by Doctors of BC, the Ministry of Health, Ministry of Mental Health and Addictions. While there is financial support, the views do not necessarily represent those institutions. As huge thank you to the medical writing team for their support developing these slides. I have nothing to disclose in terms of financial sponsors. In terms of a potential conflict of interest, do want to declare that I do receive honoraria from the BCCSU for preparing content and presenting today. Again, a note about financial support, in-kind support, of course, from the BCCSU. Mitigating potential biases that may occur in this process. All of the content is reviewed and then validated by an independent scientific planning committee and is approved for accreditation submission. So what are we hoping to cover today? We're going to chat a bit about what we refer to as point of care or in office is another way of referring to this type of urine testing, and then confirmatory or lab-based urine drug testing, and some clinical scenarios in which one might be preferred over the other, how to develop an approach that's both safe and effective to obtaining urine drug tests, and trying to figure out what you're looking at when the results are sitting in front of you. For those who want to do some extra reading after this because you feel like we haven't spent enough time talking about urine, there is a breakout resource that's available publicly to anybody. You can just type this into a search engine of your choice with BCCSU, and you can get access to this readily. So why do we do urine drug tests? It is to confirm that to confirm that individuals are in fact using opioids before we initiate opioid agonist therapy. It could help us make an assessment as to whether people are adhering to opioid agonist therapy. It can help confirm an individual's self-reported use of a number of substances. It may help us confirm the presence of substances that the patient may inadvertently have been ingesting. And it can be a tool to help us in part evaluate how individuals are doing in terms of treatment response and outcomes. A little bit about vocabulary, what is scheduled, what is random. Scheduled are where people come in at a predetermined time and provide urines, most commonly their appointment day. And then random is exactly that it's not associated with any scheduled or expected time for which they would be providing a urine. Rather, it's your staff or someone in your clinical team will be calling the patient at a random time and requesting that they come in within a certain period of time. Usually that's 48 hours to provide a sample. This is the preferred method in that it actually increases accuracy and results in terms of a random result will kind of give you a better idea of what an individual's accessing. If you call a patient or your team calls a patient, or even in an appointment type setting and the patient's declining to provide a urine that day, the process that should be undertaken is one of reassessment, and certainly is not a direct, patient not providing urine, should no longer be provided treatment. So we're really not looking at that as a direct connection. It's really an opportunity to explore what that might be about. A common question is, how often should we be urine drug testing? And I have to say, this is one of the pieces that got shook up a little bit for me during COVID. But if you want the exam answer to that, you want to be doing a urine drug test kind of in an initial confirmatory manner to ensure that there is actually opioid use occurring. When you're going through a period of stabilizing, so inducing or inducting and stabilizing a patient, monthly seems to be the best recommendations. And at maintenance, what you'll see has shifted is at the prescriber's clinical discretion. And I think, we used to have a pretty steady number that we would say you should be doing in terms of a urine drug test in an individual who's on maintenance therapy. But some of us started questioning, there's a year into maintenance and then there's 4 years into maintenance, and do you do the same amount of testing in individuals? And so I would say it's, at the prescribing clinician's discretion, but also within the context of the patient you have in front of you, where you live, how far they're driving, all of those pieces come to play a role. When individuals are at a point of stability that they have take-home doses, the current recommendations are 2 to 4 random tests if they're per year, if they're on buprenorphine, 6 to 8 random tests if they're on methadone, and same for slow release oral morphine. So, fairly easy to adhere to the 2 to 4 random tests per year, even during COVID. I will say it was difficult to adhere to 6 to 8 random tests during COVID, and perhaps some of us have pulled away from those higher range numbers. So what should this actually look like, when your patient comes in? We refer to these as supervised urine drug tests. These are not witnessed. There does not need to be another human being in the bathroom with the patient for multiple reasons, most of which is, respect and honoring a patient's right to privacy and the trauma-informed approach you would want to take in that situation. What does a supervised urine drug test look like? It means, the patient may leave their backpack or large, heavy items of clothing in a safe location while they go to the bathroom to provide a sample. Sample containers should not be easily accessible by individuals who shouldn't be having access to them. Like with any other lab type of test, you want to confirm a patient's identity. You want to ensure that your patient actually knows what they're being asked to do, so ensure that you're giving them appropriate instructions. And then you want to also check the temperature of the urine sample. Point of care tests are immunoassays, so they're antibody linked, right? So they're the preferred type of urine drug test for patients that are on opioid agonist therapy. They can be conducted in office. You don't have to send the sample off-site. When you are doing it at a local lab, the standard UDT will demonstrate opiates. So that's morphine, codeine, heroin, anything that's connected to the poppy plant, hydromorphone, amphetamines, benzos, cocaine metabolites, and a methadone metabolite. What are the advantages? They're fast because they're in your office, and you get those results immediately. They're portable, they're easy to read and use. They can read multiple substances at once, and they're relatively inexpensive. Why might you choose not to go with them, or what are the disadvantages? The concentration of the urine can impact the ability to detect the results. So someone with very, very dilute urine may show up as negative. It detects a class of substances rather than a specific drug or substance. Usually there are 1 or 2 exceptions to that. because it is an antibody type of test, cross-reactivity can lead to false positives. It is qualitative in that it's either there or it isn't. It doesn't tell you how much or how recently. And while we said an advantage is it's easy to use, some people would say a disadvantage is it can be counterintuitive on how to read it. All of that being said, now that everybody's read a million COVID tests at home, I think we're getting better with this idea. Sorry, I can't see just the top there. So what are you looking at when you look at a test that says it's positive for opioids? So as we said, if it says, positive OPI, that's really looking at opiates, so derivatives of the natural poppy plant. So we're talking about heroin, codeine, morphine. They do not reliably detect semi-synthetic, so oxycodone, hydromorphone, buprenorphine, or synthetic opioid, like fully synthetic opioids, fentanyl, methadone, meperidine. Urine drug tests for synthetic and semi-synthetic opioids can be ordered. What does that mean? It means you can actually get separate strips that test for those specific things. All of us know this now, 7 years into fentanyl being on our streets. False negative results and cross-reactivity are entirely possible and do occur. For those of you that are visual learners, this does a good job of showing you why something may show up as a positive OPI or opiate and why it may not. So as we discussed, the synthetics like fentanyl, meperidine, methadone, oxycodone, they're not going to show up reliably on an opiate screen. I think the important part of this slide is if you test positive for cocaine, it's a fairly reliable, or probably the most reliable indication that we have at a point of care test that the individual did in fact consume cocaine. So cocaine, the urine drug test actually recognizes an active metabolite called benzylethylene. It's got super low cross-reactivity with anything else. So if it's positive, it's pretty reliable that it's positive. Some patients will, or some individuals will say or believe or question whether there might be some cross-reactivity with other like cane medications like prilocaine, lidocaine, and that won't be a reason that someone would have a positive cocaine point of care urine drug test. And then on the other end of the spectrum, we've got amphetamines and methamphetamines. So this is the class of substances for which there is the highest degree of cross-reactivity. It can be from sympathomimetics, so like cold medications, ephedrine, pseudoephedrine will absolutely give you or can give you a false positive result. And therefore it's less reliable when you're looking at a positive test result to say, oh, I'm so certain that this in fact is due to my patient engaging in the use of amphetamines and methamphetamines. So it doesn't mean it's not useful. It's just important for you to understand what you're looking at when you look at that positive result. Benzodiazepines. So this was less of an exciting topic, I'd say 2 years ago, but obviously in today's current environment, and as we have an increase in contamination of our street drug or street opioid supply, with benzodiazepines, this is becoming more and more of an interest. So the antibody or the immunoassay that we have for point of care is really best at detecting benzos that are related to oxazepam and anything that kind of exists in that metabolism pathway. So chlordiazepoxide, diazepam, temazepam. Lorazepam, clonazepam, alprazolam, they have a completely different metabolic pathway, and therefore they don't cross-react and often will show up as a negative benzo point of care urine drug test as a consequence. Then the next question that I'm sure everyone's going to ask is, what about atezolizumab or the other benzodiazepine contaminants? And because nothing can be easy, the answer is yes and no. There's really been no reliable that, you know, if it's got atezolizumab in it, it will always show up positive or always show up negative. We're seeing both true positives and false negatives at very similar rates. There is a question about whether we need to include cannabis at a point of care test. It really is something that sits with, you know, the clinician. I will tell you in my own clinical practice, it's actually just included in the cup that we use. I can say it almost never, like 99.99999% of the time, does not change my approach to care. A couple things, if it is important in that clinical setting, a couple things to know are that synthetic cannabinoids, so nabilone, will not cause a positive result, but Sativex or Marinol do contain THC and cannabidiol and can cause positive results. And we also see false positive results. So there are certain medications and other substances that may actually result in a false positive. So what if you really need to know and you're sitting there looking at a point of care test and it's either not telling you what you thought it would tell you, or it's not telling you everything that you need to know? This is a situation in which you want to order confirmatory tests. Confirmatory tests are done by sending the sample to a lab. On the requisition, you want to write the word confirmation or confirmatory. If you write urine drug test, they're just going to do a dip at the lab. So make sure that confirmation word is written somewhere on the requisition. So point of care, as we said, uses antibodies, immunoassay approach. When you write confirmation in the lab, they're going to use a gas chromatography mass spectrometry approach or liquid chromatography. And ideally, you're going to write confirmation of the specific substance or group of substances that you're interested in having assessed. So confirmation for, as in this example, writing out morphine, codeine, heroin, or you can say confirmation for opioids. A lot of us these days are writing confirmation, read benzodiazepines, and now the labs are getting really good at just running that entire panel. If you write benzos, you don't need to write the specific benzodiazepine, like the individual ones that you're looking for. And again, remembering that we really only need to be doing this when the result will impact clinical management. What are the advantages and disadvantages? It is more specific and more sensitive when you're using GCMS or gas chromatography, or liquid chromatography for that matter. It can absolutely confirm this presence of specific substances. It can look for substances that aren't included in your point of care immunoassay. Atezolizumab would be an example. It detects the concentration of the substance present in a sample. And therefore it is both qualitative, so yes, it's there, no, it's not there, and quantitative in that how much is there. The disadvantages, it's pricey. It's far more expensive than point of care tests. There's a delay in receiving the results, less and less of a delay, I would say, in the last few years, but you're still not going to have the results for at least a day or two. And the results have to be interpreted cautiously, because sometimes you'll find active metabolites that may not represent what the individual consumed, but could be interpreted as such. So what happens if you're sitting there and you're looking at something that you didn't expect? Either based on your interpretation of the patient's history or review with the patient. Regardless, you're looking at a test result and it's not what you thought. Just a reminder that the urine drug test is not the end all be all, and it should not be the only factor. when you're making treatment decisions. Before you're making treatment decisions, you want to consider the other pieces of information that you have available to you. So the medical record, PharmaNet, have a conversation with that patient before going over the urine drug test. Have curiosity around the patient and what may have changed for that individual. Have an exploration of whether the current treatment regimen or treatment plan is actually aligning with what the patient is capable of adhering to, or if it's meeting the patient's needs. And use this as an opportunity to really review the treatment plan and the patient goals. So the one that I think can often cause us a lot of distress is, what if it's negative for the opioid agonist therapy agent that you're prescribing? So in some cases, and now we're talking about point of care tests again, false negative results are possible. Potentially this is explained early in the induction and stabilization phase by missed doses. The one that I think many people jump to and is of course a possibility is diversion, particularly if you've got a pattern of repeatedly negative urine drug tests. And then of course the combination of a very low dose and unusually dilute urine. So are these common? No, but could they happen? Absolutely. If you're facing this situation, what should you do? I can't emphasize this enough, is have a conversation with the patient. Don't make a decision or a determination about treatment access without that conversation. So chat with the patient and say, hey, have you been managing to get to the pharmacy to take your medication? Has there been anything that's happened and may explain why you might have missed doses? Or have you been in a position where you've felt that you needed to give your medicine to other people? Inform them of the result. Order confirmatory tests. So a confirmatory lab result, or talk to your neighborhood friendly pathologist. If even in conversation with the patient, it seems that this test result doesn't make sense. You may want to review or revise the treatment plan. You may believe that in that setting, for the safety or benefit of ongoing patient management, that resuming daily witness ingestion is a good option. And then just a note that if there is a repeated pattern of diversion attempts, it is reasonable to return to daily dispensed doses at the pharmacy. What if you're looking at a result that's positive for other substances? So substances that you weren't expecting. Of course, there is a possibility, particularly in the setting of a point of care test, of false positive results. It may indicate concurrent substance use. It may indicate a concurrent substance use disorder, or ingestion of contaminated substances. So again, using the benzodiazepine example. What should you do in that setting? The answers, you guys, are going to look almost identical to the answers for the other one. So look at what you have available to you. That's your patient, that's PharmaNet, that's medical chart. Chat about the risks of concurrent benzodiazepine and opioid use if that's appropriate. And then all of the other conversation pieces that we talked about, including the opportunity to use the lab for confirmation. And then a question about whether, or a concern about whether the sample may be adulterated or substituted. So you look at it and the color seems off, the temperature seems off. What might be happening? Sometimes patients will add water to a sample. It may be a synthetic sample or another individual's urine, or substance added to the sample. And again, you guys, the answers are the same. So basically, the take-home message is, if it's not what you expect, have a conversation with the patient, review what other pieces of information are available to you, consider sending the sample to the lab.